This is our Canadian Research Showcase this morning, and I'm really delighted to introduce Dr. Kathrin Stoll, who will be presenting on clinical and experiential outcomes of midwife-led care in British Columbia and the future of the caseload model, which is such a, intriguing title that makes me many questions already, and you haven't even said anything. Kathrin is a senior research associate in the Birthplace Lab with the Midwifery program at the Faculty of Medicine at University of British Columbia. Kathrin's area of expertise is midwifery and reproductive health research, specifically looking at midwifery outcomes, midwifery workforce issues, respectful perinatal care, and evaluation of perinatal services. Kathrin has also published extensively on fear of childbirth, rural perinatal health, and home birth. She has co-led development of several measurement tools that assess the quality of perinatal care and the perspective of service users. Many of those tools are available on the Birthplace Lab website, so I would direct you over there because there's some really excellent resources. Kathrin has worked with the interdisciplinary research teams in Canada, the US, Australia, South America, and Europe, and enjoys mentoring emerging scholars. Kathrin is going to be joined kind of near the end of this presentation with her co-author, Michelle Turner, a midwife in BC. So Kathrin and I also, this is a shameless plug, just recorded a podcast conversation about midwifery outcomes in BC. It's the first episode of our new podcast series called Conversations on Midwifery Experiences, Education, and Evidence, and we'll put the link in the chat to that, and you can go and listen to it. So welcome, Kathrin. Really delighted that you're here, and if you want to go ahead and load your slides now, I will turn off all my stuff and I'll let you know how they load. I'll wait till they're kind of up and ready.
Thank you.
Yeah, that looks great. Perfect.
Yeah. Thank you, Beth, for the introduction and the plug about the podcast. I look forward to listening to it. I'm pleased to present on clinical and experiential outcomes of midwifery care using two data sources today. One is a provincial survey of, one is the provincial data set retrospective cohort study that we published last year in the CMAJ. And the other source is a national study of childbearing people called the RESPECT study that had people reporting back on pregnancy experiences in Canada going back to 2010 and up to 2022. I will also present findings from some midwifery workforce surveys that I was involved in to kind of start a discussion about the future of the caseload model in BC. And as Beth alluded to, my colleague Michelle Turner will join me towards the end of the presentation. I want to acknowledge that I'm calling in from the traditional and unceded territories of the Musqueam, Tsleil-Waututh, and Squamish nations, who are the original stewards of these lands. As a way of introduction, I will just briefly mention the midwifery model of care in BC that was prevalent during the 10-year study of the cohort study that we did. And of course, now we have more and more midwives working in alternate practice arrangements. But at the time, the most prevalent model was one where midwives worked in teams of 2 to 4 midwives, providing medical care during pregnancy, birth, and up to 3 months postpartum in the community and in hospitals. We have the option of a home birth, and we don't have birthing centers in BC. Midwives in BC are autonomous primary healthcare providers who are regulated and well integrated into the healthcare system. Now, one thing I want to mention is that the profile of midwifery clients has really changed between 2000 and 2018. Back in 2000, about 27% of midwifery clients had a home birth, and in 2018, that number dropped to 14.5%. And back in 2000, 75% of prenatal midwifery clients were also attended in birth by midwives. And in 2018, that number dropped to 65%. So midwives are delivering fewer of their clients that they see during pregnancy. And of course, we know that rates of obstetric interventions have increased quite a bit during that time. Now, we wanted to do this retrospective cohort study in part because of what we found in a 2018 midwifery survey, where we asked midwives how many people out of 10 had complex medical, social, or emotional needs. And midwives noted that 4 out of 10 clients had complex needs. And that is something that I wasn't aware of myself, but it really made me want to look at outcomes of midwifery care according to different medical risk profiles during pregnancy. And for this cohort study, we couldn't look at really social risk very much. It's mostly focused on medical risk because of the data we had available. So the aim of this retrospective cohort study was to compare perinatal outcomes among midwives and family physicians. And we wanted to really include every midwifery birth and every birth by a physician, because previous studies had often restricted analysis to a low or moderate risk cohort for midwives, which was completely, the right thing to do in the early years of regulation. But we felt that, 20 years into regulation, it was time to look at midwifery outcomes across the board. So if we do that, though, we have to account for medical risk fairly rigorously, because it's difficult to compare midwives with obstetricians otherwise. And I will tell you in a moment how we did that. We were looking for the best way to look at, midwife-led care. How can we define that? And we decided to go with the most responsible provider, which is defined as the care provider who is responsible for the care and treatment of the client for the greatest portion of time during the stay in the healthcare facility. And for home births, a midwife is always the MRP. We were really reassured when we found a validation study conducted by Kelly Thiessen et al. That did a chart review and sort of looked at the alignment between the MRP and the prenatal provider. And they found that the alignment was more than 90% for physicians and midwives. And that made us feel confident that we were in fact measuring midwife-led care during pregnancy and birth. We used a risk stratification tool to create low, moderate, and high-risk client groups. And this is a tool that comes from the Alberta Perinatal Health Program. Our co-author, Dr. Luba Butska, worked in Alberta and was familiar with that tool. And it includes pre-pregnancy demographics, health conditions, obstetric history items, and also current pregnancy complications. And in studies, this score has been shown to correlate really highly with adverse perinatal outcomes. We were able to extract all but 4 of the 45 components. And here's a quick screenshot of what that looked like. Not all of the items are shown, but you can see that in the last column here, there is a weight attached to the item. And essentially, items that are more strongly correlated with adverse outcomes have a higher weight. And we then summed all of these weighted scores into one score that ranged from 0 to 22. And we then recoded the score into low, moderate, and high risk categories. And then going forward, we analyzed everything within those categories so that we only compared midwife-led care with OB-led care within the low risk cohort or within the moderate risk cohort. Here's a quick summary of our primary and secondary outcomes. I won't go into it too much. You will see those again when I go over the results. In the paper, we generated descriptive statistics, basically the proportion of the outcomes across the MRP group. In the paper itself, we report relative risks, which is a good choice when you are looking at some common outcomes like spontaneous vaginal birth. And then during the revision process, we brought a statistician on board and also decided to generate adjusted absolute differences, which I will focus on during today's presentation. If you want to look at those statistics, you would have to go to the appendix in the publication. I think it's appendix 3 or 4. We used a lot of the variables that were available to us to create the risk.
Kathrin, I'm wondering if, I think we lost sound, Kathrin, for a brief moment.
Are adjusted for. Beth, can you just confirm that you can hear me?
I can hear you again now. I don't know what happened there. I think you cut out just a little bit for the last few moments. Um,
I think
do you
it's,
want?
let me just go into my, can you hear
Oh
me
yeah.
now?
Yes, I can hear you well.
Okay, you know what? I'm just going to put my headphones away further so they don't automatically connect. Just one moment.
Okay,
All right. Okay. Apologies about that.
no problem. We're back on track.
Great. So we started with over 400,000 mother-baby pairs, and we excluded from that cohort births that were not delivered by a midwife or a physician, including those with an unknown or no attendance. We kept the twins and multiples in the cohort and ended up with 425,056 births, of which 15% had a midwife as the MRP, 45% a family physician, and 40.5% an obstetrician. And now I'm going to start with the first results slide that we published in the paper. It shows the proportion of births to the different MRPs that were delivered by obstetricians. And I think that is important information to start with. And as you can see here, as medical risk increased, both midwives and family physicians collaborate increasingly with obstetrician specialists. For example, obese delivered 13% of low-risk midwifery clients, 20% of moderate-risk midwifery clients, and 48% of high-risk midwifery clients. This means that 1 in 2 births counted under the midwife MRP group in the high-risk group is delivered by obstetricians, as would be the case in the event of a C-section, for instance. Here we compared MRP groups on several variables and found some notable differences. We know that in rural and remote areas of our province, a lot of family physicians serve childbearing people, including those with enhanced surgical skills who perform cesareans. We found that among midwifery clients, there was a higher proportion of those with a history of mental health conditions, which there could be different reasons for it. And here, midwives had much lower rates of antenatal hospital admissions than obstetricians, and all of those variables are controlled for in the models. Then down here, we can see that midwives and family physicians serve similar proportions of low, moderate, and high-risk pregnant individuals. And I also want to mention that in the whole cohort, there were just over 12,000 home births, and 80% of those were low risk, 19% moderate risk, and 0.5% high risk. This is a very busy slide, but I want to spend a couple of minutes describing it because it will help you understand the other results that I'll be showing. So on the left here, I copied descriptive results for the primary outcomes, and the first 4 primary outcomes across MRP groups and within those risk strata. And here I've kind of blown up one of the results, low birth weight. I have enlarged this, and you can see here that, there's different proportions. So for instance, midwife-led births that were high risk, 16.7% had low birth weight compared to 29.3% among obese. And if we look at this difference, it amounts to 14%, actually 12.6%. That's the unadjusted absolute difference by looking at those 2 values. Now in the table below here, you can see that here we compare midwives and family physicians regarding low birth weight, and here midwives and obese. And the number in the blue oval circle shows an adjusted absolute risk difference of minus 14%, meaning that births that were deemed high risk and led by midwives had an absolute reduction in the risk of low birth weight of 14% compared to high risk births led by obese, after controlling for those variables I showed you earlier. Now we're looking at the other primary outcomes, and I've graphed the results that you can see in the supplemental table of the absolute differences here. So this is basically showing that to the right-hand side of the vertical line, there's outcomes where the risk was higher with midwife-led care, and to the left, the risk was lower. And the longer the bars, the larger the difference. And if you see the green bars here, that denotes a significant difference. If it's a white bar, it's not significant. So let's start with perinatal death up here. For perinatal death, we found no significant differences between midwife and family physician-led care across the risk groups. Here, when comparing to obese, we did find some differences for low and moderate risk clients who had significantly reduced risk of perinatal death, but the absolute difference was small. It was minus 0.3%. So the risk of a perinatal death for a midwife client would be like 0.3% less than an OB client. We also see that midwife-led care was associated with a significantly lower absolute risk of preterm birth and low birth weight. And these were all significant associations, and the differences were more pronounced when looking at midwives versus obstetricians. And for UPGAR scores, we see that with the exception of high-risk births, midwives had a lower risk of having babies with an UPGAR less than 7 at 5 minutes. Now I want to speak briefly about cesarean birth, which was one of our primary outcomes. And this is again the descriptive table. And you can see here that low-risk midwifery clients had a C-section rate of 7% compared to 12 for family physicians and 42 for obstetrician-led care. And when we, for instance, when we look at the absolute differences, we can see that low-risk clients had an absolute risk reduction of 34% when their MIP was a midwife compared with an obstetrician. Now let's look at the secondary outcomes of oxytocin induction and mode of birth and breastfeeding initiation. High-risk midwifery clients were significantly more likely to experience induction with oxytocin compared to OB-led care, with an absolute adjusted difference of 11%. And this is probably one of the few findings we found where there was a higher risk with midwife-led care. But this was only for the OB midwife comparison for the high-risk clients. For the other comparisons, we see significant differences in favor of midwifery care. We found significantly higher rates of spontaneous vaginal birth right here when comparing midwives with physicians. And again, the difference was more pronounced comparing midwives with OBs. There were also higher VBAC rates, and those findings were significant with one exception here, the high-risk group comparing midwives with family physicians. And also we found a positive impact of breastfeeding initiation here and lower cesarean section rates, as I mentioned earlier. I will now briefly talk about some of the limitations of the research. There's 3 that I want to highlight. The first one is that the prenatal risk scoring system may not have adequately captured the severity of risk. And if that is the case, then we can't really control for that aspect. And there's a good chance that we didn't capture more complex conditions that likely would have been under OB care. The other major issue is selection bias. It's a cohort study, so it's not a randomized study. Childbearing people self-select into OB versus midwifery care and family physician care. And I know from research I have myself been involved in that, people gravitate towards obstetricians sometimes because they want a medicalized birth, even if they don't need it. And people might have a midwife because they want a less medicalized birth. So there is that selection bias. I also want to point out that the prenatal risk scoring tool was not validated in BC prior to use and included 4 fewer components. A few key points and take-home messages from this research are that midwives and family physician clients serve similar proportions of low, moderate, and high-risk pregnant individuals, which is something that people might not have known before. There was a common perception that midwives cared for only low-risk clients. And we're also happy to say that this study provides population-level evidence that midwives provide safe primary care for clients with different medical risk levels, because we included all of the births by midwives. And of course, further expansion of midwifery in BC will help address mandates to lower C-section rates and will also help address the maternity care provider shortage. Before I move on to the experiential component of the presentation, I want to quickly contextualize the findings in terms of Cochrane reviews that we have access to. Jane Sandel publishes a midwife continuity of care Cochrane review every few years and just published one again in April. And this one included 17 studies involving almost 20,000 randomized people. And they found that women receiving midwife continuity of care were less likely to experience C-section and instrumental birth and more likely to experience spontaneous vaginal birth. And these findings align with our results. They likely found no difference in labor induction, breastfeeding initiation, low APGARs, and low birth weight, preterm birth. These are all variables we looked at in our study, and we found a difference, and they did not. Now I'll draw your attention to one more Cochrane review here that included systematic reviews, and I think 70 of those had outcomes data, which the authors analyzed. They found that for preterm birth, there was a clear benefit of continuity midwife-led models based on 4 systematic reviews. And for perinatal death, they found 1 systematic review that found a clear evidence of midwife-led continuity models of care for all pregnant women. So we do have some contextualizing evidence from these Cochrane reviews, and there's much more evidence out there that I'm not reporting here. Now, regardless of what we would have found in our study, we would have still recommended that we needed a more enabling environment for midwives in our province. So our findings suggest that more continuity-based midwife-led care in BC may really be the way to go in terms of lowering operative delivery rates, and there's a lot of promise with expanding midwifery. But we really wanted to highlight that that has to be done in a way that is accompanied by policies and payment structures that support retention, integration, and interprofessional collaboration between midwives and their physician colleagues, what the ICM calls an enabling environment. And of course, the ICM also has a lovely position statement that says that people, childbearing people of all, risk profiles should have access to midwifery care. So I'm now going to pivot and tell you a little bit about experiential outcomes of midwifery care based on a national survey that I'm closely involved in at the Birthplace Lab. The principal investigator of the lab is Dr. Saraswati Vedam, and she was presenting on this project during last year's symposium. So you might have had a chance to see her presentation. If you haven't heard about the study, I will briefly talk about the design. It's a community participatory action research approach we use. And we worked with recruitment coordinators in 18 regions and organizational partners to try to really recruit many different childbearing people who had a pregnancy experience in Canada over the past 10 years. We want to collaborate with our community partners to look at the data on equitable access to respectful perinatal health services with a focus on communities that are historically underrepresented in patient experience data. And we hope that the results will be used to help childbearing people in Canada to expand access to rights-based, high-quality perinatal services using both traditional KT and innovative KT that we're currently developing. A quick slide about the breakdown of our participants. We received responses from close to 6,100 people. And while previously our surveys were kind of heavily focused towards midwifery clients, we were happy to have good representation from OB clients and midwives, and underrepresented a bit by family physician clients. 75% of our respondents identified as white, 7% as Indigenous, and 18% as Black, Latina, Asian, Middle Eastern, or multi-ethnic. We were able to offer the survey in many different languages, and here is a breakdown of how many people started the different language versions, with English and French being the most commonly used. So let's get into the results here. This one is about leading decisions about perinatal care. In the RESPECT study, 88% of respondents who reported on a previous pregnancy said it was very important for them to lead decisions about their care, and 36% said it was important that their midwife or doctor lead decisions. And not surprisingly, among midwifery clients, there was a higher proportion who wanted to lead decisions, and a lower proportion who wanted their healthcare provider to lead decisions about care. We also found that midwifery clients, almost all of them, said it was really, really important that they find a healthcare provider who's a good match for what they value and want. Another question we asked in the survey was about declining care and whether people had at any time during pregnancy, labor, or birth declined care offered to them or their babies. And in previous surveys, we always ask that question. And interestingly, it's almost always about 50% of people who decline some kind of care, of between 40 and 50%. And among midwifery clients, there is a higher proportion who decline care, which makes sense given the midwifery model of care and how it supports autonomous decision-making. When we asked people what they declined, we gave them many different options, which you can see here. And these are the results just for people who had prenatal midwifery care. And I just want to quickly go over the most commonly declined tests, which are medications for the baby, followed by genetic screening and testing, a lab test, and medications for the childbearing person. So those are the top ones, but you can also see people declining, C-sections and induction and forceps, etc., and being weighted, which ties in with Cecilia's presentation. Now, here I'm showing you both what people would decline in a future pregnancy and what they declined in the most recent pregnancy. And there is kind of a disconnect between some of those tests and procedures. But what I found interesting is that, more people would decline interventions in a future pregnancy than they did in the most recent pregnancy. And of course, there could be many reasons for that. They might not have felt comfortable declining that in the previous pregnancy, and they might want to do that in the future. But either way, to me, it indicates that this disconnect here where people have some, maybe negative feelings about what happened during birth, leading them to then want to decline those procedures in the future. I think I'm going to skip past some slides here. So key points, and I didn't show you all of the slides, but I'll give you the key points, is that the majority of childbearing people want to lead decisions about care, and most look for a healthcare provider who aligns with their values and needs. And I didn't show you those slides, but when we measured respectful care and person-centered care, we find that midwives score much higher than physician clients. But when we look at respect and autonomy scores for different populations of people, we see some gaps there for both midwives and physicians. For instance, when we looked at respect scores for those who needed social services during pregnancy, midwives had lower respect scores for those who needed more social services than no social services, and that trend was sort of apparent across all of the care provider groups. So there's a bit of a need to close that gap between respectful care for different types of childbearing people with different experiences and circumstances. So we'll move towards the end of our presentation, where we talk about midwifery workforce surveys a little bit, and where Michelle will tell us more about what's been happening in BC in the last couple of years. So as a quick reminder, in 2017, we surveyed BC midwives and looked at factors associated with burnout. And I won't go into the details here, but we did look at caseload, both the overall number and the number of complex cases, and we did not find an association between burnout back in 2017, which might change if we had a larger sample size. But burnout was certainly related to intentions to leave the profession. We also asked midwives in that survey to tell us with text responses what can be done to reduce occupational stress and burnout. And these were the 4 areas that they talked about. There was a thematic analysis done of those comments by midwifery students, and these were the 4 areas. Then the next year, we used those 4 areas and other solutions within those 4 areas to create a list of basically solutions to reduce burnout and occupational stress. And we asked midwives in 2018 to rate those in terms of how important they are. And here are the top 10 rated solutions, which Michelle will go into a little bit in a minute, but essentially better support for taking smaller caseloads, was at the top, followed by pension program and more off-call job opportunities and increased wages per caseload. Now to finish up here on my part, in 2018, 14% of midwives were dissatisfied with the caseload continuity model. And there were many different reasons for that. But what I always remember from the comments is that, that balancing act between financial security in BC and quality of life, work-life balance, and quality care in terms of providing high quality care. So it will be interesting to see how this will change now that midwives have had a pay increase and some other more supports from the government. And this is when I will give it over to Michelle, who will tell you more about the changes in BC since the last survey.
Great, thank you, Kathrin. So to understand some of the changes since 2018 and the possible futures of caseload midwifery, I thought it important to give you a little bit more context of BC midwifery in terms of the nitty gritty. So midwives regulation in BC defines midwifery as providing care during normal pregnancy, labor, delivery, and the postpartum period up to 3 months. And Kathrin, if you could just switch to the next slide, perfect. So this is different than, say, for example, the Northwest Territories, where preconception care is within scope. Midwives in BC prescribe medications and order exams within parameters set out by regulation and refer to other healthcare providers on indication. And these definitions aren't always intuitive. For example, midwives can prescribe hormonal contraception and insert hormonal IUDs here, but not copper IUDs, and only for 3 months postpartum. Unlike in some provinces, midwives can do very little under delegation. For example, midwives can't perform point of care ultrasound in BC, even with additional training, which can lead to additional administration, work for clients, and sometimes prevents access. Midwives are generally paid by billing the government directly for pregnancy care in trimesters by lump sums. So first, second, third for the birth and for the postpartum. So basically 5 sums that are possible. This finances most of what we think of as caseload midwifery. Midwives in this model are self-employed and run businesses, meaning out of these fees, we pay clinic overhead for rent, equipment, and administrators, pay for mileage for home visits, and manage the practice, often without compensation. In hospital, most midwives in BC are well supported by nursing staff, often with the nurses providing one-to-one care, and like GPs, midwives manage and consult as needed. Up until late 2016, there was a cap on the number of births midwives were allowed to attend annually. This was removed, which has led to higher volume midwifery practices emerging that may, for instance, not offer home births or home visits, as these are typically more labor intensive. And perinatal healthcare provider shortages are very real in BC, and so higher volume practices can help mitigate these gaps. However, it also shifts midwifery practice away from the continuity and community-based models that support some of the outcomes already described by Kathrin, including lowering interventions at cost savings. Another important change is that in 2018, in response to midwife requests for additional support while on call, consultative care code fees began. So this is closer to a fee-for-service codes, where a midwife might, for example, ask another midwife from outside the practice to do a home visit on their behalf because they're busy at a birth. That home visit midwife could then bill directly for, say, a 40-minute appointment within limitations set out by the province. So prior to these fee codes, a midwife needing the support would have had to pay that midwife out of pocket, decreasing their wages earned. And these codes can also be used for midwife consultation by other healthcare providers. For example, a midwife doing lactation consultation for an OB patient, or for when a midwife has a skill set beyond their peers, for example, referral to a midwife with expertise in ADHD and pregnancy. So initially, these consultative care codes didn't seem to change the model of care, and they were mostly used to provide support to caseload midwifery. However, particularly with the high rates of burnout and illness with COVID, with midwives needing to change the ways they practice, these codes allowed midwives to specialize and find ways to adapt their practice to support local needs and remain in the profession within alternate practice arrangements. So this means that there are midwives in BC who now work as postpartum-only midwives, for example. In the last 2 rounds of contract negotiations, there were also substantial changes, in part due to arbitration, strengthening the context for midwifery labor in BC. Kathrin, could you switch? midwives were able to negotiate a modest RRSP contribution and extended benefits plan, because of those Council of Care codes. I would say there are a few more off-call job opportunities, though most of these are centered in larger urban centers where specialization within a narrow scope can provide income generation, and very few of these off-call job opportunities occur within health authority leadership positions. We recently received a pay raise that decreased the gap between our pay and the pay of GPs doing comparable work. And one could argue that with higher wages, including a top-up for home birth, there's better support for taking smaller caseloads, potentially maintaining caseload midwifery models. Though that doesn't necessarily amount to the robust support that is often needed for care providers offering around-the-clock urgent care in the community. So, for example, if a practice was to need urgent support in the event of a midwife medical leave. Is there equity with other healthcare providers? I would argue not yet. Are there alternative or salary pay models? Well, not yet, but the Ministry of Health has agreed to a working group for a salary type model for midwives, as well as for scope expansion. These are important steps, which are changing the midwifery landscape in BC. So, what does this all mean for midwifery futures? For policymakers, I would also ask you to consider at what point will midwives be trusted? So midwives have shown themselves as skilled in managing complex care, both within our direct skill set and through collaboration with healthcare providers to optimize outcomes. This offers reassurance that midwife expansion, particularly in rural and remote communities, is appropriate to support safe perinatal care close to home, with specialists like OBs available for consultation and high-risk management. Midwives have shown that when given opportunities, they can strengthen their skills through continuing education to support unmet community healthcare needs. Midwives already have many skills that are arbitrarily limited to specific periods of time. For example, prescribing contraception only for 3 months postpartum. Midwifery skill sets could be used to increase access to primary care across the lifespan. Moreover, scope expansion is imperative to meeting colonial obligations for reconciliation with Indigenous communities so that Indigenous midwives can reclaim well-person care throughout the life cycle, as highlighted by IMAC. Is there a caseload midwifery future? I don't know. The barriers to providing caseload midwifery care are often exhausting, even if meaningful. However, with recognition of the good outcomes associated with these models and with continued strengthening of contracts for midwives, there might be one within a range of ways of practicing to support varied communities.
Thank you so much. This is fantastic. I'll turn Catherine's mic back on, and looks like we've got lots more reading we can do with these QR codes. So we'll leave this up maybe for a minute so people can look at all of these in turn and check out more information. But thank you so much, Catherine and Michelle, for that summary. There was so much there, and I already have so many questions. So I don't want to hog the questions, though, because we only have a few minutes left, and then folks will be kind of moving on with their day. But I see there's a couple of questions in our Q&A chat already. So back to the perinatal outcomes study, Catherine, that you mentioned first. One of the participants here today wanted to know if you differentiated the data according to socioeconomic status of clients, or if there was maybe any kind of analysis of demographic characteristics, for example.
We did not, because we only use perinatal data from the BC perinatal database, but it could be done by applying for data through Population Data BC. They have linked databases, so there is some opportunity for linkage. It just would require much more funds than we had at the time, but it is possible to link some of that data with more sociodemographic information.
Yeah, that'll be a next spin-out study from this original work. That would be fantastic. Okay, and Sandra has another tech question for us. I love these questions. Keeps us thinking and keeps us engaging in kind of where technology is taking us. So have you considered researching or driving the inclusion of AI in supporting midwives to decrease burnout? So other professions like physicians use generative AI for note-taking or machine learning technologies to reduce administration, coding, etc. So yeah, and Family Docs in Ontario got some funding to include generative AI in their practice. Any thoughts from either of you on how AI could help impact midwifery care, midwifery burnout?
I will say something briefly from the literature, and then I'll hand it over to Michelle. I did a scoping review with a medical student on factors associated with burnout, and definitely a higher administrative caseload is linked to burnout. So anything that can reduce that, workload and give midwives more time to do the work they really want to do with clients would be beneficial. But Michelle, can you think of any ways that AI might be useful?
Yeah, no, I would agree, Kathrin. I would say so. The short answer is I'm not aware of any research in BC and or funding in BC to support midwifery practice through the use of AI. Yeah, however, I could imagine ways in which AI could decrease administrative work. That being said, I also think administrators are a valuable part of our team and offer kind of a welcoming space for clients when they arrive. So I think, like any technology, I think it's important to be judicious, as a midwife would say. But it would be helpful. I mean, anything that could support the smoother running of the practice and decrease that workload on midwives would be
Yeah,
great.
I agree. And I think, Sandra, I know this is the space that you find yourself in, research and practice as well. So maybe we need to have a separate kind of workshop or discussion dedicated to that topic and do some brainstorming and then go get some funding like the family docs. I think that would be amazing. Any other questions for our speakers? Sandra says yes. Okay, let's bring it on. We'll do that. I think, every time I hear you talk about the perinatal outcomes research, Kathrin, I just think, we have to shout these findings from the rooftops. And to your point, Michelle, about, when will midwives be trusted? When will they become or be seen as a regular integrated part of the healthcare system who can have a powerful impact on outcomes? I think these are the questions we have to be asking ourselves. And I think of Cecilia's comment about TikTok and social media and things. I almost think like your findings are so important that we need to think about a way to really share them widely so that people can truly understand the impact that midwifery can have. And there's something fascinating going on about preterm birth, isn't there? That's one of the things that stands out to me. I mean, it was in the Cochrane review that you mentioned before, and I was aware of that, but it's really highlighted in your study as well. Do you have any thoughts about what's going on there? What's with midwives and preterm birth and why we have such a big impact?
I mean, I can give you my sense, but this is just my one midwife opinion. I think one of the values of relationship-based care is a few things: that clients will reach out to us because they trust that we'll respond, hopefully, to their concerns. And also there are factors such as they also might be more willing to disclose things like smoking or substance use or factors that impact or mental health, like things that impact the preterm birth rate, that allow for us to work with clients to mitigate against that. So, for example, taking harm reduction approaches to smoking cessation rather than a client not disclosing that they are smoking, let's say, cigarettes. So that's kind of my general sense, is that relationship side really makes a difference. I mean, we know that that's what the research suggests indirectly through the work we've also talked about, but that's a bit that I think often gets overlooked. And I sometimes feel that, midwives aren't particularly phenomenal, but in knowing our clients and thinking about and knowing context, we can often provide more personalized care, which I think is much harder to do when you don't have that context.
Mm-hmm. Yeah, that was such a great example. The smoking harm reduction, I think, you're absolutely right. It's just this creating the space in the relationship, asking the questions, making it okay for the answer to not be what, people think they need to say. And then how that can be used as a, further kind of way of shaping care, managing, kind of further interventions and the whole cascade that can come from that. Did you have anything to add, Kathrin?
No, because I'm not a clinician. I think I will defer to the two of you, as you know the ins and outs of midwifery care on the ground. But the data certainly shows a positive impact.
Yeah, absolutely. I took a screenshot of that one with the graphs of the absolute risk reduction. It's such a powerful example of how I think what a big impact midwifery care makes. And, if we could get to the point where we can see it as a powerful intervention, then why are we not sharing it with everyone else, right? It needs to be applied more broadly, but then it also speaks to the need to address the workforce issues that you've also been tackling. So I really appreciate the work that you've been doing. And I think all of these bits of research fit together so nicely for us to better understand what we do as midwives, but also to be better able to talk about how midwifery can have an impact and the considerations that need to be done to do that, effectively and to create that enabling environment.
Thank you so much for having us.
Yeah,
Thank you.
our pleasure. This was fantastic. We probably should wrap up there, even though I could talk to you for hours. So I'm very grateful for everything that you've shared today. And I think this has been such a fantastic way to start our week. We will have a brief poll again, just to get some feedback about the sessions today. And just want to also draw your attention to our plan for tomorrow. So the symposium continues with day 2 tomorrow, starting at noon Eastern Standard Time. And this is a special gathering tomorrow for an international panel. And we would love to see you there, and tell a friend and bring them along. And we can't wait in tomorrow with our next part of the symposium. So thank you everyone joining us, and enjoy the rest of your day.